Now,
Hi, everyone. Good morning, good afternoon, good evening, wherever in the world you are watching today. I would like to welcome you to the WSPOS Worldwide Webinar number 18. Today, we're excited to bring you a wonderful panel to discuss issues and topics related to inherited retinal dystrophies, the child who doesn't see. Today, I am very pleased to be joined by my co-moderator, Dr. Eduardo Silva. We're hoping that through today's content and discussions and questions that we can bring together this group of experts as well as take your expertise and your input, because as WSPOS's ethos states, expertise resides all over the world. So for some housekeeping announcements, we'd like to remind you that this is supposed to be interactive and we're ready to discuss and answer your questions throughout the webinar and during our discussion points. So feel free to send in your questions through web link, Facebook, YouTube. We'll be getting those throughout the webinar and pushing them out to our group to hopefully answer. If we're not able to get to your question, don't worry. We're going to compile some of the answers later and upload them to the WSPOS website, where you'll be able to view them and continue to learn about this content. The other thing we do have is the Mentimeter page. So if you're able to open that in your web browser or scan the QR code that's on the screen, the code for today's webinar is 87011551. So this will be our agenda today. We're pleased to have this wonderful panel. We're going to talk about lots of different topics, including what if it's not a retinal dystrophy, patients who have light sensitivity and nystagmus, syndromic retinal dystrophies that you might need to know. Are we able to go to molecular testing? Yes or no? And talking about gene therapies. The Q&A session we're going to sprinkle throughout and also hopefully have discussion here at the end. So what I'd like to do is hand the screen over to my co-moderator so he can introduce our panel today.
Hello, good morning, good afternoon, good evening, good night, everyone. It's really a pleasure and an honor to be here in this WWW18, our new WSPOS webinar on inherited retinal dystrophies. I'll start by introducing my co-moderator, Hannah Skanga. She's a licensed genetic counselor by the American Board of Genetic Counselors, and she works currently at the Children's Hospital in Pittsburgh with our friend Ken Nischel. I will be co-hosting with her, and I'm currently based in Lisbon, even though I did part of my training at the Wilmer Eye Institute, and this has been one of my main interests in throughout life as an ophthalmic a pediatric ophthalmologist. Then our first speaker is the first star of the day, Dr. Elias Trabulsi is professor of ophthalmology at Cleveland Foundation. He's the director for the Center for Genetic Eye Diseases and director of the department. He's also very well known as being the editor for Ophthalmic Genetics and executive VP for the International Society of Genetic Eye Diseases and Retinoblastoma. He's joined by Alina Dumitrescu, associate professor of pediatric ophthalmology at the University of Iowa, and she has several hobbies, including this that we can see here on the screen. She enjoys flying small planes and also, well, having fun outdoors. Subhas Chakrabarty is our guest from India. He's a molecular geneticist trained in India and also at the NIH. His lab has been engaged in several lines of research, including a lot of what's known about glaucoma genetics, but he also devotes himself a significant amount of time doing translational research from bench to bedside for things as inherited retinal dystrophies. And he loves sharing or spending his time with his family, driving around and visiting a lot of cultural places all over the world. Last but not least, Aaron Nagel is assistant professor in Los Angeles, California. He's a retinal surgeon and he has a very active life as both as a VR specialist, but also doing some laboratory work that will eventually lead to new therapeutic approaches and gene therapy. We will start our session. I need to share this with you. I love this sentence. Being humble means recognizing that you're not on earth to see how important you can become, but how much of a difference you can make in the lives of others. And that's really the goal here. Let me remind you that the Menti code for today is 8701-1551, and I'll hand over to Dr. Trabolsi for the first lecture of the day. Thank you very much, you all, and I hope you enjoy this webinar. Stop sharing.
And while Dr. Trabolsi is getting ready to present, I just want to welcome everyone who's joining us from around the world. We have viewers from Singapore, the United States, Argentina, Iran, Italy, India, the UK, Portugal, Colombia, Chile, Spain, Egypt, the UAE, Jordan, Ireland, Indonesia, Thailand, Philippines, Brazil, Mexico, Switzerland, really everyone all over the world. Thank you so much for joining us today.
Thanks, Hannah, and thanks, Eduardo. It's a delight to be back for another one of these webinars, and I'm delighted to join this group of friends and experts in the field. The topic of the day is about childhood blindness with a focus on inherited retinal diseases. But what if this is not a retinal dystrophy? If we look at statistics about the etiology of childhood blindness from various countries around the world, we have data from the schools for the blind, such as in this paper, and we see that up to a third of those causes are indeed inherited diseases, and many occur in childhood. However, this is not the case all over the world. And in Ethiopia, for example, vitamin A deficiency and measles are a major cause of visual impairment in children. In Zimbabwe, it's corneal disease, 75% of childhood blindness. And the relative contributions of genetic factors also occur probably in a smaller percentage of children in those countries. There's a recent paper that I would recommend that you take a look at from a group in England, where they looked at prospectively at a cohort of children with visual impairment, blindness, and associated conditions. And they defined visual disability as an impaired visual acuity to 0.5 logmar or worse. And they found that the cumulative incidence of visual impairment is about 1 in 1,000 in children under the age of 18 years. Half of the cases presented in the first year of life. And most were caused by cerebral visual impairment, retinal disorders, or optic nerve disorders. They also found that the incidence was higher in children from ethnic minority backgrounds, lower socioeconomic status groups, and those that were born prematurely. They had 784 children, 72% has significant non-ophthalmic impairments. So those children with multiple problems. 4% died within a year after the diagnosis of the visual disability. And if you look at the breakdown of where the visual impairment came from, cerebral cortical, 48%, retinal dystrophies, 16%, optic nerve disease, if you add hypoplasia and atrophy, that's 26%. So let's go to, I have two cases to quickly share with you. The first one is a 7-year-old boy who came because he had failed vision screening at school. He was myopic, had been in glasses for a while, but his mother noticed that even with the glasses, he was not seeing well. His medical history was unremarkable, it was very healthy, no night blindness. His mother and his sister had reduced vision and myopia, but we had not examined them up to then. His best corrected vision in the right eye was 20/60 and the left eye 20/100. He did not have any nystagmus, no strabismus. His color vision was reduced on the Ishihara plate. And this is his fundus. He had no pigmentary changes that one could appreciate. There was no foveal hypoplasia. The discs appeared slightly pale, but that was about it. We brought the family in, examined them, and indeed, his mother and his sister were both, somehow visually impaired and were high myopes. And both on examination had optic atrophy. Both his mother and sisters were also suffering from some hearing loss, and this is the audiogram of his mother, and you can see there's sensory neural hearing loss in both ears. We tested him, and although he was not complaining of hearing loss, he had mild sensory neural hearing loss. So we have a patient here now with optic atrophy and deafness. This is the differential diagnosis: the Wolfram syndrome, mitochondrial disorders, of course, a number of rare, very rare diseases. And one of the more common situations that we encounter is dominant optic atrophy, but I was not aware of the association with deafness at the time. We did genetic testing of the OPA1 gene, and indeed, this patient, this family, had a mutation R445H, and it segregated very nicely within the pedigree, and was later on described in a number of other families who had this combination of optic atrophy and deafness. We followed him now for a long time. His visual acuity is at 21/25. His hearing is stable. I started following up his mother too, and she has lost additional vision over the time. The second case I recently saw, a 5-year-old girl referred because of poor vision in both eyes, no difficulties with vision in dim lights, no color vision deficits, no systemic health issues, no neurological deficits. And the question from her really sharp and astute referring ophthalmologist, is this a retinal dystrophy? He was not convinced. Her eye exam, uncorrected, her vision was 21/50 in the right eye, 20/70 in the left eye. She was myopic. And with her myopic correction, the vision in the right eye remained at 20/80, although it was the less myopic of the two. The other one we could correct to 20/20. I will show you the pictures of her optic nerves, and you will notice that they don't have a cup. The disc in the right eye, maybe temporally, has an area that looks a little bit smaller. The overall size of the disc is also slightly reduced. And she did undergo an ERG to rule out a retinal dystrophy, and it was okay for her age. And the pattern reversal VEP actually showed delays in the P100 response only in the right eye. We got an OCT, reduced nerve fiber layer thickness in the right eye, and kind of borderline in the left eye. And on MRI, it turns out that she does have optic nerve hypoplasia of her right eye. Optic nerve hypoplasia, by the way, is one of the 3 leading causes of childhood blindness in the US. It is due to subnormal number of optic nerve axons with preserved blood vessels and glial tissue support. It's congenital, non-progressive, unilateral, or bilateral. There's a wide spectrum of severity and may be associated with pituitary hypoplasia, other central nervous system defects, and, as you know, endocrinological problem. I'll just show you a couple of pictures. This is a patient with severe optic nerve hypoplasia, another one with severe optic nerve hypoplasia. I would label this as moderate optic nerve hypoplasia. There are also 2 other variants. One is segmental here in the left eye. You see the upper half of the disc is kind of reduced or decreased in content of nerve fibers. And what I've observed in a few patients, I haven't seen that published yet, but an inferior sectoral kind of optic nerve hypoplasia. How does optic nerve hypoplasia occur? It could be the result of mutations in genes involved in optic nerve or chiasmal formation, in genes involved in retinal ganglion cell development, differentiation, or guidance. We see it in the context of mitochondrial diseases. I've published on that, and in mutations in gene that regulate apoptosis. But there's also a lot of environmental factors that could be involved, including exposure to alcohol of the fetus, as well as others. All of this leads to this phenotype of optic nerve hypoplasia. So what I want to leave you with are these few messages. Number one, that optic nerve disorders are common causes of vision loss in children. They can simulate retinal dystrophies. Electrophysiologic and molecular genetic testing are extremely helpful. And it is extremely important to make an accurate diagnosis because of the potential associations with other systemic manifestations. And they are totally different if we're talking optic nerve disease or if we are talking retinal dystrophies, as we are going to hear later from Hannah. So I thank you for your attention, and I want to take this opportunity to invite you all to the upcoming meeting of the International Society for Genetic Eye Disease in September 3rd to 5th in Lausanne, Switzerland, in person or virtually. You can visit our website, isgedar.com. Thank you.
Thank you, Dr. Trabulsi. Very important points we all have to think about when we're considering our differential diagnosis, whether the vision loss appears to be stable or progressive. So I'm hoping to definitely link in some ideas with you when we get to the talks and the discussions today. So now I'd like to welcome Dr. Alina Dumitrescu to present about light sensitivity and nystagmus.
Hello, everyone. Happy to be here today and really happy to see you. We are going to move next into light sensitivity and nystagmus in early childhood. And I will present two cases to kind of illustrate the potential differential diagnosis of this topic. The first case is a 5-year-old female that presented with extreme photophobia since age 10 months. Family and patient report poor quality of life due to photophobia. Visual acuity on exam was 20/80 in the right eye and 20/50 in the left. And because of her photophobia, the slit lamp exam was limited, but show relatively clear cornea. Additional history, normal pregnancy and delivery, normal growth and development. She passed the newborn metabolic and hearing screening, but failed a recent hearing test, and she's scheduled for hearing aids. Had nystagmus in the first year of life, which has improved since. Parents are healthy and have no ocular or hearing problems. There is a positive family history of consanguinity. We decided to proceed with an examination under anesthesia because of her difficulties with light, and her intraocular pressure was elevated to 25 and 29, but her pachymetry was quite thick. Axial eye length was normal, corneal diameters were normal. On the anterior segment exam, there was a diffuse corneal haze and endothelial bullae, some of which were ruptured. Fundus exam was normal, including the optic nerve. A sedated full field ERG was at the lower limit of normal, which for all in all conditions, which was considered pretty much normal for a sedated ERG, and she was having low hyperopia and some astigmatism on cycloplegic refraction. So at this point, the differential diagnosis was between congenital glaucoma or corneal dystrophy. Although her pressure was a bit high because of the cornea being thick and because of no other signs of glaucoma, we focused mostly on corneal dystrophies, and we discussed that with families. Of course, we also gave her glasses mostly for astigmatism. Genetic testing was done with a corneal dystrophy panel, and it showed 2 disease-causing mutation in SLCA4A11 gene on the chromosome 20, which is diagnosis for CHED, congenital hereditary endothelial dystrophy, which is an autosomal recessive disease, and both parents were carrier for 1 mutation. Now, the combination of CHED and hearing loss is suggestive of Harboian syndrome, which combines the two, and it makes sense because CHED is secondary to an atrophic endothelium with thickened descemet membrane, and the malformation is caused by defective endothelial cell adhesion. And the gene encodes a transmembrane protein and is expressed in corneal endothelium, fibrocytes of the inner ear, and renal epithelium. Harborian syndrome, the kids that have it develop hearing loss later in life. Their corneal dystrophy starts early, but the hearing loss develops late. No reports of renal disease with this disease so far that I know. And because not all patients with GED have hearing loss, it might have some additional environmental or some other factors that are associated with it. And for some reason, Harborian syndrome is more commonly reported in consanguineous families. The treatment historically has been penetrating keratoplasty, but more recently endothelial keratoplasties have been performed. And temporarily, hypertonic solutions or non-steroidal anti-inflammatories can be used. Our patient underwent DSAC in both eyes, and these are her pictures, and her vision has improved and her quality of life has improved. She also got hearing aids, and she's doing well with those too. The second case is a 2-year-old female. She presented with congenital nystagmus with onset at age 6 months. She does not like bright sun and squints even in normal daylight and indoor per parents' report. They also think her vision is not particularly decreased and she knows her colors. She again has normal growth and development and passed newborn metabolic and hearing screening. She was delivered 2 weeks prematurely, and there is history of some prenatal exposure to alcohol and a family history positive for glaucoma on the paternal side. On exam, visual acuity by Leah block match is 2500 in the right, in both eyes at distance, and 2100 at near. Pressure is at the upper limit of normal by eye care. On color vision, she only recognized 2 out of 10 plates on the Matsubara test, but she can name most of the color, and she's only 2. She has nystagmus and a low myopia with astigmatism on refraction. She was unable to perform OCT, but on her fundus photos, as Dr. Trabulsi was showing earlier, you kind of see not a full double ring sign, but maybe a crescent temporally that is more pronounced on the left side, kind of suggestive of a possible optic nerve hypoplasia. The pigmentation is somewhat decreased, although there is pigment in the fovea, and the foveal reflex is somewhat blunted. And her awake full field ERG is normal in the dark adapted ERG, while the light adaptive is borderline normal amplitudes with delayed latencies. And it's similar in both eyes, only right eye showed here. So at this point, the differential diagnosis for her nystagmus or vision loss could be optic nerve hypoplasia, maybe oculocutaneous albinism. Could this be achromatopsia? As Dr. Trabulsi was saying earlier, optic nerve hypoplasia could be associated with pituitary dysfunction, so we proceeded with an endocrine evaluation and a brain MRI, which were normal. And we discussed it with parents that ocular albinism is not high in the differential because of lack of iris transillumination defect, and there is still seem to be some fovea form, and the pigmentation was mildly decreased and kind of in line with ancestry. Achromatopsia could be, although the ERG is not typical and her exam is not typical, but they wanted to know because they wanted to have other children and they want to know if they could be affected. There are genetic testing for all these conditions, but due to many reasons, we decided to do it one at a time. And we started with condystrophy panel, which was positive for 1 known mutation and 1 new nonsense variant predicted to be pathogenic in the CNGA3 gene. The two variants segregated with parents and their diagnosis for achromatopsia. Again, because her exam was not absolutely typical for achromatopsia, we actually followed up with an albinism panel that was negative. And we counseled the family that this is likely achromatopsia at this point. There are no treatments for achromatopsia currently other than tinted lenses that seem to improve visual acuity in some patients. In her case, her myopia progressed a little bit. She got glasses with myopia and astigmatism correction. Tinted lenses did not make a huge difference, but she likes it and she wears it. And there are a number of clinical trials for achromatopsia going on right now, and they are enrolling pediatric patients. She's not part of any of them currently. So in conclusion, the differential diagnosis of photophobia with nystagmus in early childhood is pretty broad and includes congenital glaucoma, corneal dystrophies, media opacities like congenital cataracts, some metabolic disorders with corneal involvement, uveitis and inflammation, albinism, retinal dystrophies, particular achromatopsia, and sometimes forceps injuries. Thank you very much, and we'll answer any questions next.
Thank you very much, Alina. For those of you that have just recently joined, welcome to this webinar. Let me start by saying that we have viewers and listeners from all over the world. There are people that have joined in from Vietnam, Bangladesh, Argentina, the Ukraine, Denmark, Pakistan, India. So we're literally from all over the world. And we're going to start our discussion now. We've seen the importance of a correct phenotype before we when we start looking at these kids, and also the importance of genetics and the of multilateral collaborations. Elias, do you have something to comment on this perspective of having a multidisciplinary approach to these kids?
I think still the two most important aspects of evaluating these children are the history and the physical exam. And you cannot beat those. Once you do a good exam and take a good history, you almost nail it every time. The molecular diagnostic and the imaging studies have been wonderful additions. Now, we always show the unusual cases, but the more typical cases, you can make the diagnosis without those if you're an experienced clinician. So again, I would say take a good history, draw a pedigree, do a good physical exam, get your testing. Hopefully there would be access to it. It's not available everywhere around the world, unfortunately. And then you make your diagnosis. And then the other question is this an isolated eye problem, or is this a systemic problem with an eye manifestation?
Yeah, I agree. Alina, do you think that we need to work up every patient with nystagmus?
Honestly, I do. I do think a significant number of patients that have congenital nystagmus that start in first year of life, have some sort of eye problem that limits their vision. And there are some that don't, and there are some that actually have neurological problems that are, the cause of their nystagmus. But I think an eye exam that is, as Dr. Trabulsi said, complete and put in the context of their development, of their history, of their family history is mandatory. And sometimes, because the diagnosis is not clear, genetic testing to confirm it is necessary.
Yeah, I agree that we need to keep an open mind and avoid treating exams. I mean, we need to look at our patients, and we really have to keep your eyes open And if you're in doubt with some signs or symptoms, ask for help. There are other colleagues from other specialties that may give you some very important points when it comes to the final diagnosis. Well, let's move on. And I would like to introduce now my co-moderator, Hannah Skanga. The floor is yours. Thank you very much for being here.
Thank you. Okay, so I'm hoping that this generates a lot of discussion with the group and questions from those of you around the world. I would like to discuss, syndromic retinal dystrophies, because often, in the ophthalmology clinic may be the first place that these children come to with their vision impairment and retinal disease. There's certainly so many syndromes out there, so I'm hoping just to touch on a few that really could change the medical care and treatment of these children if we can identify their other extraocular features early. So of course, I'd like to start with one of the most common ones that we end up seeing, Usher syndrome, the most common inherited cause of sensorineural hearing loss and vision impairment with the retinal phenotype of RP. And when we think about, trying to type these children as type 1, 2, or 3, the history, as Dr. Trabulsi and Dr. Dumitrescu both elaborated on, asking those sorts of questions about the onset, the timing, the severity can help start to peg hole people into these different types based on the hearing loss. And as well with their imbalance issues, often seeing delayed walking in children who end up having type 1 and variable types of vestibular issues in type 3. When we think about if we're unable to capture them by genetic testing, what other sorts of management tools might we have available? So of course, that audiology evaluation to get augmentation going, whether it be hearing aid or cochlear implant. Audiology ongoing evaluations are particularly important in patients with type 3 who have a progressive form of postlingual hearing loss. Making sure we're getting speech assessments for young children, developmental assessments, and if we're looking for those vestibular findings, specific testing for that is available. One of the most familiar is the rotary chair test. All the forms of Usher syndrome are autosomal recessive, and I have the genes displayed here. There are panels that capture these, but of course we have to think about the overlapping syndromes that may look like Usher syndrome, but actually are a different condition. As often the retinal dystrophy and the hearing loss may be the first signs, but what if there's more? So Usher syndrome is one of the syndromes within the ciliopathies group, and there are many more conditions in this, but the ciliopathies are the retinal dystrophy phenotype, and it can be variable depending on the underlying ciliopathy. You could see rod-cone, cone-rod, and the different variants in the pigmentary appearance. But these children and moving into adulthood can have wide-ranging extraocular features because these conditions affect the non-modal cilia throughout the body. So hearing loss may be there in childhood. We may see obesity, congenital defects like post-axial polydactyly, congenital heart defects. A big risk for people with these conditions are the medical renal disease due to the nephronophthiasis and the ciliary defects that have occurred in the kidney. Liver as well as something that can be a feature and can really contribute to some significant morbidity. When we think about evaluations or testing, one thing that we've adopted here in our center as a protocol is getting a renal ultrasound scan on any child with an early onset retinal dystrophy. We have unfortunately seen children as young as 1 or 2 years old already displaying signs of medical renal disease, but not yet symptomatic. And so capturing these early and getting them to the right service can really be life-changing. Thinking about neuroimaging, I'm thinking about some ciliopathies like Joubert syndrome. You'd be able to make your diagnosis upon observing the molar tooth sign on the brain MRI. Cardiac imaging is important when we see patients who have retinal dystrophy with cardiomyopathy, thinking of Alstrom as one option. Endocrinology evaluations, checking for hormonal imbalances, diabetes, skeletal surveys for the different skeletal disorders that can present with retinal dystrophies. If you see children with small abnormal rib cages, they're in the NICU, they're having respiratory insufficiency, these sorts of imaging can also help point to the diagnosis. Of course, audiology and our medical genetics colleagues Most of these disorders, again, are autosomal recessive. There are some that are X-linked, and there are many genes with phenotypes you may have heard of, like Joubert syndrome, Bardet-Biedl, Senior-Loken. I mentioned June asphyxiating thoracic. There's also Alstrom. So these are many overlapping conditions, and genetic testing combined with all these other extraocular evaluations through your phenotyping can help rule in or out some of these conditions and really direct the surveillance. If I'm thinking about some other syndromes that really could make a difference if we get to a diagnosis, Zellweger spectrum disorders, thinking about those defects that occur in the peroxisomes that end up leading to retinal dystrophy, plus a host of other conditions. The retinal phenotype, it is a pigmentary retinopathy, but as you can see, this is a recent case of ours here. We're not seeing the typical bony spicule pigmentation of RP. In some children who have a very similar disorder of adrenoleukodystrophy can also see, sometimes it's referred to as the leopard spot pigmentation. So these are some things we can see. And when we think about what their extraocular features are, they can have very severe neurologic involvement. And unfortunately, in the most severe form, do not survive past the first year of life. But we can also see people with moderate and mild Zellweger who may have a very late diagnosis. Looking for those intracranial anomalies, hearing loss, the enamel hypoplasia can really be a key to some of the milder phenotypes. They may appear to be Usher, but with hearing loss and retinal dystrophy, but have tooth issues. Always an important question to ask. And the liver disease comes on due to a bile acid synthesis problem that actually in some patients can be supplemented. And there is an FDA-approved medication for that at this point. If we think about evaluations and testing, aside from genetics, metabolic labs can be very insightful. Very long chain fatty acids would be highly elevated in this condition, as well as some other metabolics like the pipocolic acid and bile acid. The neuroimaging, as mentioned, the liver function testing can be critical to get them to management early because it, eventually with the chronic liver disease that does come on, if you are going to replace bile acid, at some point it can be more harmful than helpful. So appropriate diagnostics and doing that at the right time can really change the course of these conditions. They're autosomal recessive and they're affecting these PEX genes, which are peroxisomal genes. I have them in order of commonality. As far as we know, PEX1 is the most common, accounting for as many as 60%. But there is another peroxisomal disorder that can look like Zellweger at first, but the metabolic labs can also help us tease it out, as well as the retinal phenotype. If we think about Refsum, so Refsum disease or Refsum syndrome typically has that retinitis pigmentosa phenotype with the patient history fitting that as well. But the extraocular features have a bit of overlap, but have some specific differences, particularly the anosmia can come on as one of the earlier features. Then because this is a phytanic acid problem in the body, we start to see the onset of some of these other conditions like a motor neuropathy and ataxia. The ichthyosis does become a problem as their metabolic defect continues to occur in their body. Hearing loss, cardiomyopathy, and arrhythmia are also something that's important. If we're looking at hands and feet of our patients, you can see some short fingers and toes in some of the patients as a critical clue. And when we look at the metabolic labs, they can help us discern these patients from some other long chain fatty acid disorders, because the long chain fatty acids would be normal here, but phytanic acid would be increased. So it can help us discern them. There are some specific tests for anosmia if your patients are endorsing that as a symptom, and really going for that echo and electrocardiogram to see what the cardiac status is. And a lot of these symptoms can fluctuate depending on the patient's dietary intake of phytanic acid, because the two genes here, PHYH and PEX7, they're responsible for either the breakdown or the input of the phytanic acid and the medium chain fatty acids and peroxisomes. So the enzymatic defect here allows phytanic acid to build up and continue to worsen the symptoms. And in patients who don't have very good dietary restriction, plasmapheresis is an option to help decrease this in the blood, especially if they're having some acute cardiac findings. And the last one I'd like to touch on today that I think is also very important is Kern-Sayer syndrome. So this is typically your pigmentary salt and pepper retinopathy. And a clinical diagnostic triad would just be someone under the age of 20 with a retinal phenotype that also is showing external ophthalmoplegia with ptosis. That can lock in your diagnosis right away and start to evaluate these other mitochondrial findings, looking for cerebellar atrophy or hypoplasia. They do have hearing loss, diabetes, and importantly, they can have a cardiac conduction abnormality, which often can be a reason for them to pass. Renal impairment does happen as well. So these are things that can really change the quality of life and can be life-saving. Metabolic labs can help with this condition if we're looking at lactate, your typical metabolic or mitochondrial marker. But there are some CSF studies that can indicate Kern-Sayer or other metabolic disorders. And a muscle biopsy, while invasive in mitochondrial diseases, would show those ragged red fibers. We can also certainly do those extraocular exams looking for symptoms that we can start to intervene with. And if we think about genetics, knowing that it's often a de novo mitochondrial deletion, there's a common deletion here that I have listed, but large deletions in the mitochondrial DNA is what's contributing to all these different health problems that we can see in Kern-Sayer. So really, when we think about, these were just 5 of very many syndromes that we may see being, the diagnosing service for retinal dystrophy, and thinking about the child as a whole and not just as the eye patient that we're seeing. And using some of these extraocular evaluations combined with metabolic tests can help us get to that clinical diagnosis. If you have access to genetic testing, it can further confirm your suspicion and direct appropriate surveillance, as well as those counseling points that need to be discussed with families. I'm hoping for a good discussion about all these today. Thank you.
Thank you very much, Hannah. This was a fantastic talk. I would like to remind you guys that there is a Menti code, which is 87011551, and there's room for questions from the audience. And the first thing, Hannah, that really comes to mind is we're at the molecular medicine age, and we're expecting to find a positive genetic diagnosis for every single patient. What do you tell parents every time the panel or NGS, whole exome sequencing that you ask for comes negative?
Sure. I think that discussion starts before you do the genetic testing. So I'm a very big proponent of pre-test counseling. Sometimes I spend more time talking about what the genetic test can find, can't find, its benefits and limitations before families proceed, because then I feel like I can really focus on what did it find or what are our next steps in the post-test discussion, rather than trying to address all those questions about, well, why didn't it find something? So I like to make sure they know that in advance. But when we don't find anything on genetic testing, I think it's really critical as the provider to make sure that the test that you ordered was targeting the conditions that you thought it was. Not all tests are created equal. So you may actually be missing either certain types of mutations or certain types of disorders, depending on the test that was ordered. But we do tell families that this is a rapidly evolving world, and I may have a panel next year that will be more inclusive, or there may be a new test that can be a diagnostic tool. So, I find being embedded in ophthalmology, as a genetic counselor, really helps me stay in touch with families to get them the newest and latest diagnostic test. But just having that awareness that this test can be negative in advance before doing it helps moderate those expectations.
Yeah, I totally agree with you. And I think it's really crucial that people understand that we're not dependent on a positive response, because there's a lot that can be done, and really there's a lot going on, and there's a lot of evolution in what kind of testing you can ask the lab, and that also the discussion between the clinician and the laboratory is crucial. And on that note, I'm going to give the stage now to Dr. Chakravarti from India. It's a pleasure to have you here. And can we go straight to molecular testing? Subbu, thank you.
Thank you. So as the question has already been asked, can we go straight to molecular testing? So the first thing that we would need to know is why we do a testing. So one, that it can confirm a clinical diagnosis, identify carrier status, confirm or rule out the presence of mutation, particularly in those who are asymptomatic. I'm not sure why it is not moving. Okay, yeah. So essentially what we are planning to do is to see if there is a risk of recurrence. Given that a family has a genetic mutation, what are the chances of that same mutation recurring in individuals who are either asymptomatic or who have the disease but have not been tested? And what we are trying to do with that is to understand disease prediction. Dr. Trebalsi, Hannah, and Alina have already alluded to the need of clinical assessment. So a deep phenotyping really goes a long way and in many ways can avoid a genetic testing. The genetic assessment is largely to do or largely to complement the clinical assessment. And it goes hand in hand if there is a very perfect genotype-phenotype correlation. Given that there is a defect in a gene or a set of genes, does it change the phenotype or does it contribute to the severity of the phenotype? And that is what molecular testing looks for. And Hannah already alluded to counseling. I'll not go deep into it, but the results finally lead to the counseling of individuals and as well as the families. For there could be various psychological assessments, cultural assessment based on their origin, etc. So in an ideal world, precision medicine would mean that a patient, when enters the clinic, we have a very well-documented family history. There is a risk factor questionnaire and the risk is assessed. But at the same time, the biological material is collected and then through a series of analysis, one kind of correlates with the risk assessment from the clinical records. And that leads to something like a personalized medicine for that patient. And in inherited retinal dystrophies, this becomes more challenging because over the period, there are huge number of loci, chromosomal loci that have been identified or mapped, and several genes that have been characterized, close to 250 genes that have been characterized. And this is the final count that you get in RetNet today. So getting back to our assessment, so if the clinical presentation is suggestive of a genetic condition, if there are very distinct clinical features, as we heard from the earlier talks, and there is a very well-documented family history, one could go in to supplement that information with the molecular assessment. So the disease may have a single gene, although we don't know that there are not single gene diseases anymore. There are multiple genes that are involved, but there could be some primary genes that are involved, particularly in that family. And one could do for a single gene sequencing, usually by Sanger sequencing, if it is negative. If there are multiple genes, one could go for panel testing. Each of these have their own limitations. We'll come to it in the next slides. So if they are negative, then one can go in for a whole exome or whole genome sequencing using trios, and then go in for discovery. So the issue here, what we are dealing with is if there are distinctive clinical features suggestive of a disease, then it is very straightforward assessment, as opposed to if there are multiple non-specific concerns. For instance, in the context of retinal degenerations, like for instance, in the context of AMD, we have many loci, many genes that have been identified. And so pinpointing causality becomes difficult, and that is where one resorts to either a microarray assessment or a whole genome, whole exome assessment. And if the disease runs in family, then since these are all usually very late onset diseases, even getting that kind of a genetic assessment becomes impossible. So given that information, what we are trying to do is trying to find out whether these are autosomal recessive conditions based on the pedigrees, and do the genetic results follow the same pattern. For instance, in the autosomal recessive inheritance, one would expect that the parents are heterozygous carriers. The affected children will be homozygous for those variants. or they may be compound heterozygous with each of the parent harboring a different heterozygous mutation. Now there's another scenario where you can have two different genes instead of the same gene with different alleles, indicating a digenic scenario in cases of recessive diseases. In case of X-linked, the females will be carriers, and the disease would be transmitted largely through the defect in the X chromosome in the males. Autosomal dominant diseases may be relatively more straightforward because the pair it doesn't skip generations, and the heterozygous alleles are present both from the parent to the offspring, and it carries on. What is more challenging are these kind of sporadic cases that Hannah also alluded to. So if there are sporadic cases which are de novo mutations where you do not really get an inheritance pattern, this is where it becomes difficult to establish pathogenicity. Sometimes this could be in the affected tissue, it could be due to the mosaics, and so forth. So at the end of the day, what we are trying to understand is, are there rare alleles that cause these so-called Mendelian diseases where you have a unique pattern of inheritance? But with the burst of data from whole genome sequencings and whole exome sequencings, we now know, and through genome-wide association study data, we now know that there are multiple other variants of intermediate frequencies or common variants which also interact with the rare alleles or the alleles that have a very strong effect, which we call mutations. These are hardly present, or they are very rare in the general population as opposed to a common variant or an intermediate variant, which will have a relatively higher frequency in the general population. But sometimes presence of this along with the mutation can actually influence both the disease phenotype and the severity. And now there are many types of techniques that are available, starting from the Sanger sequencing or the chain termination method, all the way to single cell sequencings. And as you can see, over a period of time, the coverages of the genome sequences have increased significantly. Now we can sequence more than 5 million, more than 75,000 reads per run. And significantly, there has been a reduction of cost per sample. And the data can also be generated in a much faster way, but the analysis obviously takes a much longer time. So I'll just touch upon two major issues that we face when we have multiple genes affected, like in inherited retinal degenerations, as I showed, that over 250 genes are involved. So there are two approaches. One where one knows if there are a set of genes that cause that particular kind of disease. One can prepare a panel, which is a more targeted kind of a sequencing, as opposed to a whole exome sequencing. I'll just draw your attention to the caveats of designing a panel. So most of the panels that are used, not only the ones that are customized in the labs, but the ones that are purchased off the shelves, often there are certain limitations with respect to their coverage. So for instance, certain panels have a very high specificity, but that specificity is only up to, let us say, 96 to 97% of the total genome or the total genes that are being assessed. But more importantly, one actually needs to find out that most of these panels, they cover the hotspot regions very effectively. But do they cover the other regions as effectively? The answer is obviously no, because there are certain regions which are very difficult to sequence. And if one goes into further details of understanding how the panel works, if you go into those genes, one can find out how many bases are missed in those across those genes when you align those sequences in some of these genome browsers like the UCSC browser. I'll just give one example, like in one of our panels, the RP-GRIP one, which is a RP-GTPase regulator gene, had 13 bases missing from one of its sites. And that brings about that 90% of one of the primers is kind of uncovered based on sequencing. Now, getting that information is important because although if you see that the RPGRIP1 gene in the panel has been sequenced by multiple primers, and most of the hotspot or the known mutation regions are covered. But what about the possibility of finding any novel mutations in those regions which are not yet targeted? So in those regions, one then needs to kind of do a separate sequencing, a short fragment or a Sanger type sequencing to kind of cover this entire gene. This is one of the caveats for panel sequencing. Now, again, there are limitations with the whole exome sequencing as well in trios, and trios are preferred because one can see not only the inheritance, but the pattern of inheritance based on the haplotypes. What happens in whole exome sequencing is more than half of the data of any whole exome sequence for an individual has synonymous variants. But there are only very few variants which are missense and which actually contribute to the disease. So one needs to do multiple trios to kind of see what are the specific regions where these variants are mapped, and then go on to characterize those regions. And again, in terms of whole exome sequencing, coverage analysis becomes important, whether it is covering whole of the gene. Is the depth of coverage uniform, or if there are regions which are not being adequately covered? And based on that, what are the number of variants that are coming out? Is it a uniform set of variants, or are there variants that are relatively low just because the regions have not been covered well? And then they are obviously filtered out to bring out the pathogenic variants using various methods that have been that are currently used based on the ACMG guidelines. Another important thing that that needs a lot of molecular assessment is the copy number changes or the repeat regions. Most of these cannot be directly sequenced, so there are other methods like the multiple ligation assay, MLPA, and in one of these assays, it has been shown that when you use a low frequency assay, you miss out regions which actually has large number of large copy number changes using a very stringent approach. Steve Diger actually assessed, and his group assessed 640 autosomal dominant RP probands, and what they found is that using the standard methods of genome-wide linkage and sequencings, they could find out half of these mutations, and the remaining could be found out by next generation sequencing. But still, there is a large proportion of cases that are not assigned to any of the genes, despite doing a targeted as well as a whole exome sequences. So there are still certain gaps, and the FFB Scientific Advisory Board, led by Jackie Duncan and others, have actually highlighted that while there are still areas that are still elusive in terms of the genetics of IRDs, so these need to be kind of understood not only based on the entire assessment of the genome, but also on the cellular and molecular mechanisms, and also correlating the clinical structure and functions. For instance, will these changes kind of correlate with the OCT changes, as some of these which were allured by Dr. Trabelsi? And then one needs to go towards therapy and regenerative medicine, which Dr. Nagel would talk about in the next talk. So what are the resources that are available for genetic testing of patients? So we have a lot of educational resources, the online catalog of genes and diseases, which is the online Mendelian inheritance in man for learning. But there are a lot of data resources like the iGene and the dbGAP, which is essentially a ophthalmic disease genotyping and phenotyping network, where one could actually get some of these informations. But more importantly, there are genetic registries, like for instance, the NIH Genetic Registry, which is a summation of 50 different countries across the globe. And these genetic labs, which are either CLIA certified or state certified labs, they usually upload these reports. And so one can get an overview of what are the different genetic tests, but also the results as to what are the different genes that are involved and what are the different variants that have been found in particular diseases. But in the long run, what we are looking into is an assessment not only based on just one molecular test, but using the molecular testing, like Hannah's talked about the metabolic testing, etc. So we are looking into multiple avenues of omics biology along with the clinical data to kind of segregate individuals into particular patterns in terms of their clinical phenotype, in terms of in terms of their pharmacogenomic profile, and so forth. So what are we trying to do? This kind of data will actually establish a kind of a risk stratified treatment for a better health outcome. But the question is, whom to test? Should we test everyone? So Dr. Trebalse, as part of this group, along with Ed Stone and others, have provided these recommendations of the AAO, Task Force on Genetic Testing, and there are very specific guidelines as to who should undergo testing, and this should be offered only in specific diseases where the causative gene is known. Laboratories need to have appropriate testing strategies. The genetic test results need to be provided to the patient for seeking further advice and also for their help in enrollment in clinical trials. Direct-to-consumer genetic testing should be discouraged, and the results should be assessed by trained professionals, genetic counselors, and others. Unnecessarily parallel testing, whole genomes, and other things should be excluded, and routine genetic testing for complex diseases where the causative gene is not known should be avoided, and also unnecessary testing of asymptomatic minors should be avoided. So to conclude, where do we go? So can we directly go for the molecular testing? The answer is no, unless indicated otherwise based on a strong clinical and molecular evidence as the data stands today. And it is always better to use your discretion towards an actionable result. For instance, if we have an actionable allele in a gene which can predict the outcome or predict the progression or predict recurrence, I think those are the cases where one needs to go for molecular therapy, molecular testing. And also at the same time, we need to adhere to the GINA guidelines, that is the non-disclosure, Genetic Information Non-Disclosure Act guidelines, which actually prevents that these things cannot be done involuntarily. And also the insurance companies cannot just use these results directly for their own benefit. So with that, I would stop here and thank you.
Thank you, Dr. Chakrabarty. Certainly gave us some points that we'll be able to talk about as a group following our last speaker. So now we would like to invite Dr. Aaron Nagel to present to us about gene therapies for inherited retinal dystrophies, a certainly very exciting and emerging topic that is relevant to many patients that we see and certainly questions that they ask us in the clinic. Thank you, Dr. Nagel.
Hi, everyone. Thank you again for including me in this amazing webinar, a great group of speakers. And you've had a nice introduction into what I'll be talking about, which is now we've done the molecular testing and identified the causative variants and how do we treat the patient. So it's an exciting time. Here are my disclosures. And I'll get right into the premise of gene therapy, which is that you have your cell and there's deficient protein production for whatever reason due to variants that were identified to be causative. The idea is to reintroduce a normal copy of that gene, and that's typically done with a virus carrying a normal copy of the gene, which gets into the cells which are still there, but not producing the correct protein, and allows the cell to function again. Obviously, this must be performed before there is significant cell loss, and so that has implications on the timing of treatment and which disorders can be treated in this way. Ideal more for autosomal or X-linked recessive conditions where you've essentially experienced loss of production of a particular protein, and simply introducing a normal copy can resume production. And Why am I talking about this as a retina specialist? Well, because it just so happens that the retina is kind of an ideal site for performing gene therapy when you look at essentially any organ in the body. This is a schematic here that the Seattle Times made when our first patient who was from Seattle got treated back in 2018 with Luxturna. And you can see they nicely illustrated the subretinal injection procedure, which delivers viral particles into the subretinal space, which allows access to the RPE or the photoreceptors in other conditions. And it's really ideal because it allows you to deliver a lower dose. There's less systemic exposure, less chance of inflammation, unlike any kind of intravenous delivery for other organs, for example. And of course, with the eye, we can see everything we've done and all kinds of imaging modalities to follow and track that patient. So that's what makes this a nice place. And I just want to emphasize also that getting to this point of gene therapy has been a long road, and I just want to emphasize, everyone who essentially worked so hard over the last 25, 30 years now, getting to this point, starting with cloning of the RP65 gene, work by Michael Redmond, Gene Bennett and Al McGuire with their gene therapy program and Briar sheepdogs, and then in the phase 1 and phase 3 clinical trials, leading up to FDA approval of Luxturna or voretigene neparvovec. So I'll primarily focus on Luxturna just because it is the only FDA approved and we have experience delivering this. But of course, as you know, there are many other gene therapy programs in clinical trials. And so that's very exciting. But this will kind of provide a pathway for these other gene therapies. One thing I want to emphasize that was very unique about the Luxturna clinical trials was that one, they treated both eyes, which originally was thought one eye only for any kind of experimental therapy, but it was done because that was what was thought would be done in the real world. And also they used this multi-luminance mobility training, or this maze, to provide a functional output for these patients who receive therapy, which was also unique, unlike many ophthalmology clinical trials, which will use visual acuity. And so they had these subjects navigate this maze at varying light levels. And the treated subjects were able to pass through the maze at the lowest light level, which is quite dim. 2/3 of the subjects could do that, whereas none of the controls could. So not only were they able to show this improvement in the MLMT, or this maze score, in the original versus the delayed intervention group, but it correlated nicely to the FST, which is this full field scotopic testing. It's kind of like a visual field. The subject does have to respond whether they saw or didn't see a stimulus, but it is a full flash, so it's not a point stimulus. And it correlates quite nicely to the maze, and that's what we're using at our site, and other sites are using it as well, rather than a cumbersome maze setup. And so again, you see the improvement, usually about 2 log units, so 100-fold increase in light sensitivity. And the visual fields also improved in the clinical trial. So moving on to delivery, how has that been set up? Well, in kind of collaboration with the FDA, the idea was to create centers that would essentially deliver this with wet lab experience prior to the first patient treated. And the idea is to concentrate expertise so that complication rates are minimized, rather than kind of letting any retina specialist deliver this treatment. I know, we talk about molecular testing and delivery and Luxturna treatment, but a lot of people are interested in what are the actual mechanics of delivering the treatment. So this is just one slide just showing the surgical delivery kind of logistics. We get 2 0.8 cc syringes to the operating room with diluted Luxturna. One is a backup syringe. We only need to use 0.3 cc's as indicated on the label. So we have a lot extra usually. Must be used within 4 hours, so that makes it kind of a logistic thing. So you have to time everything right. And we use the Med1 microdose kit, which is essentially, if you're familiar with silicone oil injection, where we press a foot pedal and it allows us to kind of inject the silicone oil in the eye, we can use the same tubing and setup to deliver the gene therapy, so that I don't have to rely on an assistant. I can essentially use the foot pedal control to deliver the gene therapy myself. And we do a vitrectomy, we deliver 0.3 cc's, we use a 38 gauge tip cannula. We treat the eyes a week apart, but we've done it farther apart for certain patients for logistic reasons. We do use intraoperative real-time OCT, and I'll show you that in the next slides. that allows it to confirm subretinal delivery, which I think is a really nice thing, and I can see it in my oculars as I'm delivering it. And then we do a full air fluid exchange to wash out any residual vector in the vitreous. This is just an example of a relatively myopic patient. I think he was a -8 spherical equivalent with somewhat of a posterior staphyloma. And you see here, I'm touching down on the retina. Here I have a live crosshair overlay on the OCT, and you can see the blood essentially expansion as I'm delivering it, again with the foot pedal control, and cannula staying in the retinotomy, and the bleb is expanding into the macula. So superior is at the bottom. This is the surgeon's view, and treating the entire macula. So that's 0.3 cc's, and as you can see, it seems to be sufficient to treat the primary area of residual photoreceptor cells. I'll just go into some real-world experience with this. So we've now treated 23 patients, so 46 eyes just at Children's Hospital. I'll only talk about 22 because those are the ones that have consented to research, about split by sex. And age-wise, we've treated as young as 22 months, so under 2 years old, which I think is still the youngest ever treated. And we've treated up to adults 44 years old. Most are children, 13 of those are children. We have pretty long follow-up at this point. What we see is very similar to the phase 3 clinical trials, which is that the visual acuity doesn't really change very much on average. We do have patients who have improvements, but on average, it stays about the same. The key point is that the full field scotopic testing, this light sensitivity dramatically improves, usually by about 2 to 3 log units of improvement. And that appears sustained now. So I'm only showing 1 year, but we have patients who are 3 years out and they have sustained their FST. Here's a really nice example of a 5-year-old who at baseline had, you can see these isopters, I'll just highlight 2,4E and then the 3,4E on the outside here, 20/80 and 20/50. At post-op month 3, you already see an improvement, widening of this 2,4E and 3,4E isopters, which she already had. But at 1 year, she has new isopters, the 1,4E centrally, and then at year 2, she now has a 1,3E in the right eye and an expansion of the 1,4E in the left eye. She's now 20/60 and she's 5 years old. So pretty remarkable. So this group of pediatric ophthalmologists, I really would ask all of you if you think that this could be an example of almost like a reversal of amblyopia in this case, and make the argument for treating younger and younger patients. So I know there's not much time, but I'll just wrap up. I'm looking forward to your questions. I'll say that as was emphasized in all the previous speakers, molecular diagnosis is really going to be the driving force if we're going to be able to cure these patients and treat these patients. But gene therapy delivery really does require a team approach. I rely on our neuro-ophthalmologists who do the visual fields, Dr. Mark Borchert, in children as young as 3 years old, optometry, pharmacy to deliver the medication, etc. So all very important. I think expertise with pediatric retina surgery in the young children, younger than 5, is important, and that's when we should be treating, in my opinion. We shouldn't be treating adults. We should be identifying them young and treating them young while their cells are still viable. So with our outcomes, we do see a non-significant visual acuity trend, significant improvements in light sensitivity, significant improvements in visual field. No major safety issues with vector, but soon we should have 1-year data from the consortium of sites that have been delivering Luxturna. And just amazing real world results in children, with children, just amazing stories, biking in the dark, seeing their shadow for the first time, really just heartwarming stories, especially in the children. And it's just exciting to see how Luxturna will pave the way for future gene therapy trials that will address many other genes and treat many more patients. So thank you very much.
Thank you very much, Aaron. This was a fantastic talk. And I think that the word for both talks, Subbu's and Aaron's, is complexity. We've seen complexity from the laboratory side, and also highly complex steps that seem very simple to the patient, because sometimes they have something, or even our colleagues, they have some things in their minds that allows them to think, oh, this is a piece of cake. This is just another cataract surgery, which is in fact not the case. We'll start the discussion now, but before that, let me remind you what the Menti numerical code is, 8701-1551. Please have your questions pumping in, and I'll start with Aaron. God, this is you have quite an experience in these cases. What are the main challenges that you face in surgery in these kids?
Well, the challenge for me is always ensuring that we're removing the cortical hyaloid. The last thing we'd want is to leave residual vitreous, have that insert on our retinotomy, and then cause a retinal detachment. So I take extra care. Thankfully, these children seem to have a pretty syneretic vitreous that is much more amenable to hyaloid separation than you would expect at a given age. Like I said, I've operated as young as less than 2 years old. But I do use triamcinolone to stain the vitreous. I'll sometimes stain twice. And I'll use a tanno brush or some kind of scraper to really make sure that I've gotten to that step. But that's the main thing that I worry about, are kind of vitreoretinal issues secondary to going inside the eye at a young age.
Yeah, thank you very much for those important pointers. Subbu, what do you think are what is the cost for some of the testing that you've discussed in your talk?
Right. So the whole exome sequencing cost varies across countries. And again, in whole exome sequencing also, for instance, the costs have significantly come down. Maybe I'll just use a calculator because I have to convert it into dollars and stuff. But the point that I would like to drive in here is that in India, if you were to do a whole exome sequencing based on just the moderate coverage of the genes, it would be anywhere between $225 to $250 a sample. But if you would go in for a very detailed coverage, and this is just a single pass reaction, but following that, there are a lot of validation tests. So that would add up another $50 to $100 if one is going to validate some of the ones that indicate, some of the variants that indicate pathogenicity. So that would be the cost in India. In the US, obviously, it would be slightly different, and the cost in Australia and other places would be kind of similar.
Well,
the other point I would like to dive in is many of them do not go for whole exome sequencing unless there is an indication to do so. Most of them, they go with a targeted approach. Like if you're dealing with retinal dystrophies, let us say you're dealing with retinitis pigmentosa and there is a defined panel, one can just use that panel. And so in taking those approaches, the cost per genotype comes down significantly.
Well, we have one question from the audience for Aaron. How long it takes to see the effects of the gene therapy treatment, the Naparvovec treatment?
Yeah, well, typically we aren't formally measuring kind of outcomes with FST or vision till 1 month after. However, I have so many stories of patients and their parents telling me that even within a week of treatment, that they were able to, for example, see that birds fly for the first time. They only saw birds kind of walking in front of them, or seeing a cloud for the first time, seeing fish in a fish tank for the first time. So really pretty remarkable improvements in contrast sensitivity and being able to distinguish and discriminate objects even just within a week of the treatment.
Yeah, thank you very much. One of the things that really concerns me is the dialogue that we have with our patients and also with the laboratory. Elias, could you elaborate on this? I mean, who is proficient enough to convey the genetic information to these individuals?
Honestly, I think our genetic counselors are the best fit to do that, and also the best fit to assess and go over the results that come from the lab. I have to admit that the reports that we get from the labs in the US at this time are extremely good. I mean, they go anywhere from, the history of the patient to what sequence variants have been identified, to the interpretation of the sequence variants and seeing if they are pathogenic or possibly pathogenic. They go through a number of algorithms for that. So yes, the reports by themselves are already quite good, but to put them in the context of the disease and what it means to the patient, I do think that the genetic counselors are the best fit to do that. Those of us who are very experienced or who are trained in as clinical geneticists would have learned how to do that too. I fear that many of the ophthalmologists out there would rely mostly on the report, and that probably would be okay for the majority, but the occasional case where there's a discrepancy between the report and the actual condition will create a situation that is difficult to handle.
Yeah, I mean, we have to combine two things. First of all, what the expectation of the patient/family is. And the other thing is that they will go, if they see the report directly, they'll go running to the web just to see what does this mean? If I have a chromatopsia, what exactly does this mean? Am I going to go blind next year or next month? Alina, do you see these cases from time to time?
Yes, absolutely. And the hardest cases are the one where there are variants of unknown significance in a gene that could actually be disease causing for their disease. And then what does that mean? Do I have this? Don't I have this? Will all my kids have this? And of course, the question, where's the treatment? And when am I going blind? Can I drive? Can I go to normal school? All those happen. And as everybody said here, if a genetic testing is negative in a setting of a very suggestive phenotype, does not mean the patient does not have the disease. And they definitely want to know that if the test is negative, what does that mean? So I do agree that testing is important, but setting the expectations and discussing in detail with the patient or the family before and after is probably the most important thing. And even for us, knowing what is in that test, what am I missing, what has not been tested, it's very important.
I definitely like to echo what you said about the family getting a negative genetic test result. And then I think sometimes the leap there is, well, then this is not genetic, which of course has implications for risk assessment. So that's where we have to go back to our clinical diagnosis and the different inheritance patterns that could cause us to make sure we're still giving some guidance. So I think that that's an important point to make sure they take away, is that a negative genetic test does not mean it's not genetic.
Yes, Elias, please.
Just to add to this last point of the negative genetic test, and to qualify what I said about who should give the result, I think it's the genetic counselor, but of course with major input when it comes to clinical implications of the ophthalmologist, because that's the person who has the experience. But with the negative results, in children, it may not be as important, but in older adults, where you could have patients who have cancer-associated retinopathy. And in my retinal dystrophy clinic, I have maybe one of those a week, or one a month, or whatever. The implications of a negative test could be extremely significant. And unless you know how to interpret that and channel them on to even a completely different service and a line of workup, you would be in trouble. And children, not as bad.
Yeah, I totally agree. I think that we really have to be on our toes to try and be as proficient as possible when it comes to establishing these dialogues, and also be humble. Sometimes it's very difficult to really, you have to keep an open mind and stay flexible, because once you reach a diagnosis, it may eventually change over time. And that is something that it's not, you don't have to be ashamed if a patient that you've classified as being a Leber's at some point develops a kidney disease, and in fact, he has the Syndromic syndrome. So that again is flexibility when it comes to the diagnosis is something that is really important. Well, I think we have to wrap up. We have 5 minutes left. It was really a pleasure to be here and be a part of this symposium. A lot of the questions that the audience have sent have not been answered, but they will be in due time. I need to thank. Let me share this. Let me share now again. Where am I? Right here. So a few thank you notes. First of all, obviously the panel. I would like to thank the panel for being a part of this endeavor. I would like to thank the audience. Obviously, this wouldn't make any sense if we didn't have an audience with us. And Todd for putting this together, our brilliant administrative team, the panel that we have here. I need to thank Novartis because Novartis is sponsoring this, not only this symposium, but it is making a huge change in a lot of these individuals and families by proving or by providing new forms of treatment. And also, I would like to remind you that there are going to be upcoming meetings, more webinars to come. Next week, we'll have malignancies in the pediatric eye, and the week after that, unmet needs of amblyopia. Please don't forget to log in and join us. Become WSPOS members. It's free. You should follow us on social media. Also subscribe our YouTube channel. It's important. If you want to revisit the past webinars, feel free. This really expertise resides all over the world. And also there's a very interesting discussion group. Contact Dr. David Granite for his listserv. And I think that we're about to be done. There's like 3 minutes. One last note from any of the members of the panel, and I would be delighted to say just bye to everyone.
And I think we're also compiling the results from the Menti survey. So while everyone's giving, maybe everyone could go around and give one last pearl that we could all take away from the webinar today, and we'll be ready to present the Menti information. Dr. Trabulsi, if you could give one pearl to our audience today, what would you say?
From my presentation was have an open mind, as Eduardo says, and keep also in mind that even when you suspect a retinal disease, it may be an optic nerve problem or a cortical visual type of impairment.
Dr. Dimitrescu, what pearl do you have for us today?
I think what I want you to remember from today, or to emphasize today, is there are many eye diseases that can be inherited. They're not all retinal dystrophy. They can reside in cornea, they can be glaucoma, they can be cataracts. And it's important to distinguish between them because the treatment and prognosis is different. And as Dr. Nagel showed us, there might be treatments for everything eventually. So let's identify all these diseases because that's where the first step is.
Dr. Chakrabarty, what word of wisdom do you have for us?
Well, I'll use the term what Eduardo used, that we need to be flexible because the understanding of the biology is improving by the day, and the dissection of the entire human genome, both not only the genome, the transcriptome, the proteome, the metabolome, everything taken together is giving newer insights on a daily basis. So I think, and that kind of reflects back into the testing, and that leads to therapy. So we need to be flexible. We need to accommodate this, and eventually, as all other panelists have said, that often there are other indicators that a disease may not be of a phenotype X, but maybe a phenotype Y. And so these are the different insights that need to go in towards not only towards our understanding of the disease pathogenesis, but that also needs to reflect in the testings, the comprehensive testings, which further will ultimately lead to a better therapy and management.
Okay, and that's a good transition to therapy. So Dr. Nagel, your words of wisdom for us today.
Yeah, so I'll just emphasize, and it's been said time and time again, but therapy really relies on solid molecular evidence and molecular diagnosis. And you all as pediatric ophthalmologists are going to be in the prime position to make that diagnosis and diagnosing these dystrophies at a young age so that they can be treated at a young age when there are a lot of viable cells still there. So I'm looking forward to the future of how we can expand on our experience with Luxturna into many other retinal dystrophies and treat more and more children.
Well, thank you very much. For the Menti results, there are a few things that we would like to share. And we're very happy to know that according to you, the best part of our webinar was the discussion, which is always fantastic. And there were some answers that were replied, but these are so many that we, for the sake of time, we're going to have to pass and probably just place them on our webpage. It's now time to close. I'll thank everyone again for participating. Thanks for being here. Thank you, Novartis. Thank you, NTOD. Thank you, the administrative team. This has been a great endeavor, and glad to be here again every time you need us. Thank you very much, and have a great weekend.